In this video, we'll discuss lumbar punctures. In lumbar punctures, CSF is collected from the subarachnoid space and can be done in two positions, lateral decubitus position and number two in sitting position. So number one, how it is done in the lateral decubitus position. The patient is positioned at the edge of the bed with knee, hip and neck flexed. And in the sitting position, patient sits at the edge of the bed with their feet on a stool or chair to flex the hips and leans forward with the head flexed and shoulders resting on a bedside table. The part is sterilized and local anesthetic is given. For example, 1% lidocaine without epinephrine. A 20 to 22 gauge needle is inserted between lumbar 3 and lumbar 4 or between lumbar 4 and lumbar 5 at the level of iliac crest. The needle is inserted between L3 and L4 because the spinal cord ends at L2 and inserting the needle at L2 may damage the spinal cord. The spinous process of L4 lumbar 4 lies along an imaginary line between the top of the posterior superior iliac spine. The structures that are penetrated to get the CSF are as follows. Number one is skin and fascia. Number two, ligaments. Which ligaments? Supraspinous, interspinous and ligamentum flavum. Then comes the epidural space, the first space, then dura mater, the first layer, and then subdural space, arachnoid matter, and finally subarachnoid space. CSF circulates in the subarachnoid space. 20 to 30 ml of CSF is removed and its opening pressure is 18 to 20 centimeter of CSF and lumbar CSF pressure is 70 to 180 millimeters of water. At a CSF pressure of 112, production is equal to absorption, and at pressure of less than 68 millimeters of water, the CSF absorption stops. So the lumbar CSF pressure is 70 to 180 millimeters of water, and at 112 is production is equal to absorption, and if the pressure is less than 68, then CSF absorption stops. So what results we get from CSF? We can get gram stain and we can culture it. Number two, cell count. Number three, we may find blood and xanthochromia in the CSF if there is hemorrhage or injury, and it is most commonly used to detect CNS inflammation, subarachnoid hemorrhage, and CNS infections including metastasis, GBS, genetic metabolic encephalopathies. Number four, it may be used to give a radio-opaque contrast agent for myelography, and its therapeutic use is done in idiopathic intracranial hypertension where 30 to 40 ml of CSF is removed if a high volume of CSF is present. So from the CSF we can get a gram stain, culture, cell count, blood, xanthochromia. We can get information about CNS inflammation, hemorrhage, infections, genetic metabolic encephalopathies, and a radio-opaque contrast may be given for myelography. And in the therapeutic uses, it can be used in increased idiopathic intracranial hypertension where the fluid is removed, and the therapeutic indications is number one, to decrease intracranial pressure in idiopathic intracranial hypertension, and can be used to administer intrathecal drugs like spinal or epidural anesthesia and intrathecal chemotherapy like antibiotics and other drugs. Contraindications to lumbar puncture: severely increased intracranial pressure. Number two is skin infection at the site. Number three is thrombocytopenia of less than 50,000 per micron liters. There is coagulation defect like increased NR and increased activated partial thromboplastin time APTT, and if there are anatomic abnormalities at the insertion site like spinal fusion or congenital anomalies. What are the absolute contraindications? Infection at the site, for example cellulitis or abscess at or near the needle insertion, and if there is an infection, cellulitis or abscess at the site, then suboccipital or cisternal or cervical C1 to C2 approach is done, but this is always done under fluoroscopic guidance. Now what are the precautions for lumbar puncture in increased intracranial pressure? Number one, inspect for papilledema. Number two, check for loss of venous pulsations in the retina CT scan.